Hello everyone, it is Dr. Locklear here, and I'm coming to you with the concept of safety, Exemplar 51B, Patient Safety, and this starts on page 2892 in your Pearson Text Volume 2. Again, we said a lot about patient safety in our last lecture, and when we were just talking about the concept of safety in general, but now we're specifically going to look at patient safety. So this is going to focus around the patient. So we're going to evaluate the quality of safety in home care settings. How do we make home safe? Right safety nursing interventions for patients in healthcare settings. Contrast lifespan considerations for safety in healthcare settings, plan nursing interventions for quality, safety, and best patient outcomes. And of course, we know that the best patient outcome is for the patient to remain safe, no injuries, no infections, to have an uneventful stay in the hospital or within their community setting or home setting. We want them to be safe. So what is our overview? Individualized patient care incorporates numerous developmental considerations. We have to consider the developmental age of each patient that we're working with. Older adults are as prone to injuries and accidents just as younger children are. Patients who present with illness or injuries are assessed not only in terms of their developmental age group, but about safety concerns for their age group. The younger child is active, they fall a lot, they lose their balance. The younger they are and they've just learned to walk, they hit their head, they're not as easy to break bones as older adults. Older adults will break bones. A lot of times they fall because of poor vision, poor fitting shoes, they're confused on medications, their vision is blurry because of medications. Medications have a lot of side effects on the older adult. It causes changes in mental status, so they'll get up without asking for help. Nurses need to take into account common injuries and safety hazards associated with all age groups across the lifespan. We're not just dealing with older adults. Why, if you work in the emergency department, you're going to have all ages in there. Consider safety should take place in all healthcare settings, such as acute healthcare facilities, extended care facilities or long-term care facilities, community settings, and home settings. So it doesn't matter where you are. If you are working with a patient, then you need to make sure that their environment is safe. We talked a lot on the other about the concept of safety, keeping the room safe. Well, what about their home environment? The same thing is in effect there as well. Safety in the home care setting. So we want to look at the home health and how it responds to the needs of the older adults. What level of assistance do they need? Do we need wound care? Do we need therapy such as speech and OT and physical therapy? Do they need homemaker services? Do they need someone to give them their medicines? Do they need someone there just to keep them safe because they get up at night they're confused from Alzheimer's or dementia? Another issue that we need to look at with the older adult population is elder abuse. And some of the signs of elder abuse is, becoming very depressed, urinating on themselves. That's the same with children, very withdrawn, telling you that people are abusing them. We need to look for cigarette burns and bruises and marks where they've been hit. So when we look at elder abuse, these are intentional actions by a family member, caregiver, or other that inflicts harm or puts an older adult at risk for harm. These include failure to meet their basic needs such as food, water, clothing, bathing, leaving them dirty, poor hygiene, or to protect them from harm, physical abuse from the caregiver, or just not watching them and they fall or they choke on food when they eat, and they're not using the proper diet. As older adult populations increase, the suspected number of unreported elder abuse cases have been underreported. And another area of abuse is financial, taking their monthly income and using it for your own self needs. Older adults with disabilities and or dementia are much more vulnerable to abuse because they can't express their needs appropriately. They can't tell you that someone's abusing them because they have alterations in their thought processes. Older adults with chronic illnesses may be taking those medicines that cause confusion or cause weakness, inability to walk, changes in mental status. Medicines can affect, all aspects of the patient's physical health. Older adults over age 65 with disabilities are more vulnerable, so they have disabilities that make them more vulnerable. Another high-risk groups are those with dementia. Victims of elder abuse and neglect also have additional health conditions such as digestive problems, depression, anxiety, chronic pain, and heart problems. Many are on fixed incomes and experience financial exploitation with very damaging losses affecting their lifestyle, which affects their ability to financially take care of themselves. It is our job to report elder abuse. Look on page 2893. It talks about promoting medication safety for older adults. And, some older adults are polypharmacy. We talked about that earlier in another presentation, but these things are being tracked now, and so polypharmacy is something that is being looked at. But sometimes it's the caregivers too that are getting these multiple medications and using them for themselves and not for the patient. Make sure you read over that on page 2893. Environmental improvements. So what can we do to reduce and address the safety risk? We need handrails on walls and stairs and grab bars in the bathroom. Wider hallways if possible, doorways for the walkers and wheelchairs, easy grip door handles, remove the scatter rugs because you can trip over those, easily accessible bell or other way to call for help. Remember, they're in a home, they may not have a call light, they have a life alert around their neck or some monitor in their room. Adequate lighting, they need to be able to see. Chair height toilets, raised toilet seats in the bathroom so they don't have to squat down so low, and it's easier to get up and down on those. Ability to control the room temperature for comfort. Remember, room temperature is for the patient, not for us. And then fire and disaster plans. Look on page 2892. It gives you examples of environmental safety. A lot of these are listed here in your text. It says older adults with one or more chronic illnesses may be taking medications that increase their risk of confusion and their mobility. Nurses who work with these patients and this population, we have to assess for risk to safety related to both prescribed and over-the-counter medications and supplements. Look at the patient teaching feature on page 2894, and it's talking about medication teaching. And so it is our job to make sure that we are doing the patient teaching regarding the medications. And if you can't do it to the patient, you do it with whoever the caregiver is or whoever's willing to listen. We have a picture here, and when we do this in class, I'm going to ask you to identify the health hazards and safety issues that you see in this picture. And there are several. And I want to see if you pick up on some of the things that I picked up on. So safety in healthcare settings. So what are we looking at here? We want to do handoff reports, and we want to do SBAR reports. And so the handoff reports between nursing units, between shifts, other departments, staff, physicians is critical. It's also a common cause of error if not all the patient information is given or there's not enough time. You have to give a very detailed report, and you want to maybe use the SBAR. What's the situation of your patient? What's the background of this situation? What was your assessment? And what do you recommend for this patient? Complicated patient care requires coordination, flexibility, adjustments among the members of the health care team. You've got to be able to do this handoff report as detailed as possible with all who are involved in the care. Critical care, but also a common cause of error if not all the patient information is given, if there's not enough time, and that you don't use the right type of handoff report. You want to give, again, like a SBAR type report for the information. And on page 2893, it gives you a great description of a SBAR report. So the situation, patient name, age, location, code status, current vital signs, patient's current status, background, what was their admitting data, diagnostic tests, oxygen in use or not. Assessment, what was your assessment findings, and what do you recommend? Please review that. Safety in healthcare settings, so we look at the common causes of medical errors, and this particular slide talks about pediatric emergency medicine, but this is pertinent for adults as well. Physician fatigue, physician burnout, frequent distractions, interruptions, poor communication with patients, families, staff, consultants, failure to monitor your patients. Remember I said you can't nurse from the desk. You need to be down in the patient's room constantly assessing. Need for rapid decisions in busy environments. Are you at a place that you can do that? Can you make quick decisions? Do you know when to call the physician? A lot of things are missed, and the patient's condition, by the time it gets so bad, it's too late when you miss those subtle cues. You have to pay attention to your assessment findings and act on them. Cognitive errors due to premature closure. So in other words, I just looked at it and I gave a quick decision and I didn't look at the whole picture. So adverse events, medical errors. In some facilities, safety may not be a high priority. They become complacent. Remember that alarm fatigue, tolerance of low performance. And I can remember a time when I was a staff nurse and I was sitting at the desk documenting nursing notes, and the secretary said, "Don't you hear that call light going off?" And I'm like, "No." And I had heard it so much that I had just tuned it out. That was an eye-opener for me, that I was getting alarm fatigue and I needed to pay more attention. So we can contribute to poor quality, patterns of unsafe behavior, and uncaring attitudes if we are not thorough and pay attention to the needs that are right in front of our eyes. Some of the other things, adverse drug events. And so what do we need to do when we have adverse drug events? This can happen so quickly. Make sure that you're following the 7 rights of MedPass. You're pulling medicines in order. You do your 2 patient identifiers. You scan your patient first, identify them, check your vital signs in your labs before you give these medications. I'll give you an example, and this is one of my pet peeves. An aspirin. An aspirin is an antiplatelet. It's antipyretic. It's given for pain, but most patients take it because they're cardiac patients and they're taking it to prevent blood clots. You should check the platelet level. Earlier this semester, we had a patient that their platelet level the day before was 50 points higher than it was the day that I checked it, and now it was like way too low. We talked to the staff nurse and said, "I'm not giving this. This is the current platelet level. It's too low." And she didn't give it either, and she called the physician. You can't withhold medications without calling the physician unless you have preset orders already to do so. Medication errors can occur anywhere in the medication process, even with starting with the prescriber. About 1/3 of inpatient hospital adverse events are due to adverse drug events, and most are preventable. So here are your 7 rights of MedPass: the right assessment, right drug, right dose, right patient, right route, right time, and right documentation. Make sure you know that. falls. Very common in healthcare facilities. Special risk for individuals equal to or greater than 65 years of age. Nursing interventions, what do we need to do? Again, keep the room clean. Get the clutter out of the way. Get the trash off the floor. Make sure the obstacles are clear in the room, the corridors, the stairwells, in the patient's home, the scatter rooms. They got on good fitting shoes. You educate them not to get up by themselves, to call for help. Make sure that call light is in reach. Make sure they can reach their water pitcher or their phone or whatever's on their table that they need. Well-lit rooms. Again, non-slip shoes. You should not be getting patients up barefoot. Assess their vision. Do we have their glasses on them? Are they clean? Are there hearing aids in place? Use of side rails. Follow your policy. Be aware of the patient's medical regimen, the side effects, and the interactions. Make sure that you know drugs. You, as a nurse, 50% of what you do is administer medications. Before we move on, I want you to look at page 2894, and it gives you these examples, and they're on the slide here. But one thing it didn't mention was over-the-counter medications and some of the types of injuries that you can have, bleeding inside your brain, death, broken bones, broken hips, and then over-the-counter medicines can interact with a lot of prescribed medicines, so we need to know what type of medications that they are on. Health-associated infections or nosocomial infections, which are acquired in the hospital. This occurs while a patient's being treated for another condition. So say I come in and I have surgery and I end up with a UTI or pneumonia. That's a health-associated infection. It can be serious because hospitalized patients are usually weaker and we are immunocompromised. If we were well, we wouldn't be in the hospital. The National Healthcare Safety Network annual report on progress at the national state level shows a decrease between 2008 and 2013, but this is 2020, so what are the numbers now? Patients can help prevent infection. They need to be knowledgeable about their treatments. Encourage patients to ask questions. Be proactive about their blood sugar control. A lot of patients are very aware of their diagnoses and how to take their medicines. Losing weight before surgery, quitting smoking. We know smoking affects our circulatory system. Appropriate hand hygiene and disinfecting techniques. Clean equipment appropriately after it's being used before being used for another patient. Safety devices, and some of them are chemical restraints, seclusion, and physical restraints. And so with safety devices, these are intended to partially or fully limit patients' mobility. Chemical restraints are those drugs that are administered to patients who are agitated and to control unsafe physical behaviors, but they can cause sedation, they can cause change in mental status, and make the patient unaware of falling and harming themselves. Seclusion is confining a patient to a room involuntarily, preventing the patient from leaving. More appropriate for emergency departments and psychiatric units than acute care settings. And you'll see this sometimes patients are put in rooms and they're put in leather restraints, and they have to have a one-on-one monitor. You have to have specific doctor's orders with time frames on them, and their care, you have to provide somebody one-on-one to make sure that their toiletry needs and their nutritional needs and skin needs are being met. Other devices that are considered forms of restraint are wheelchairs that have a tray over the top of them so they can't get up, bed rails, follow your policy at your facility for bed rails, and Geri chairs. Those are the chairs that they sit in that look like they're recliners. If the patient can release or remove the device without assistance, it's not considered a restraint. And so one of the things that you want to do is make sure that you try other alternatives before you put a restraint on the patient. Some other safety devices are infant and child restraints, crib nets, elbow restraints, mummy restraints, keep them from pulling out their IVs and tubes and things like that. Physical restraints, wraps, buckles are tied to the patient's arms, legs, or trunk, which limits their movement. They can't move. One of the most unsafe restraints is a vest restraint, because if the patient tries to get up out of bed, and believe me, they can get out of bed with a restraint on, it can get around their neck and they can literally hang themselves over the side of the bed. Restraints cannot be used as punishment for convenience or to prevent the patient from leaving the facility. Here are some different types of restraints. You've got the vest restraint, the Geri chair, wrist restraints, an elbow restraint, chemical restraints, your medicines, 4 side rails up, and you need to know your policy on side rails, because some places require 3, some are okay with 4. Safety devices. We have regulations stipulate conditions for using restraints. You have to have a physician or a provider must order the restraint. You can't just put a restraint on somebody. The order cannot be standing or PRN. It has to have a time frame, and it has to address an urgent need to protect the patient and others right then. Restraints can be applied in physician notified ASAP, especially in a situation where there is harm going to occur, but you have to notify the physician. Legally, a competent patient who simply does not comply with care may not be restrained. Could be construed as assault and battery or false imprisonment, and there have been many lawsuits about that. Restraint alternatives and least restrictive forms must be tried first. Putting them up at the nurse's station where you can see them. I've actually worked in a facility where we put the mattresses on the floor, so if they tried to get up, they just rolled off the mattress. I know it doesn't look very nice, but it was a safety measure. If unsuccessful, then chemical or physical restraints can be implemented as a last resort under the direction of a physician. Must be documented evidence of least restrictive measures that were tried. And when they're in the restraint, you have to make sure that you're addressing their needs. Restraint alternatives: have someone stay with the patient if possible, bed or chair alarms, distraction, limiting the number of staff in and out of the patient so they don't agitate them, de-escalation strategies, and these are listed on page 2895. Use distraction and diversion. Use a calm and soothing voice. Speak in your normal tone. Don't go in all excited yourself, because that's going to upset them even more. Put a tracking device on them. Reorient confused patients. Bed alarms. Assess or address what's causing them to be agitated. What can I do to help you? Offer therapeutic self and reassurance. Let them know that you're there and that, you're going to meet their needs, and do that. Physical effects are depression. They feel dehumanized, feeling of being punished. Guidelines for restraints: assess at least every 2 hours or sometimes more than that. Look at skin and circulation. Are they too tight? The patient's response, the effects. New verbal order needed every 24 hours if no written order. You have to do a trial removal of the restraints for patients to freely move body parts and provide range of motion, reposition, toilet them, offer food and fluids, and evaluate to determine if it needs to be continued. So, like I said, they'll have somebody one-on-one with them if they're in restraints. The type of restraints, again, I showed you a picture of those, and here's some listed here as well. Limb, belts, safety roll wraps, vest restraints, and again, the vest restraints, one of the most constrictive. Limb and wrist restraints, mittens, soft belts, immobilizers, and the mittens. Wrong site, wrong injury. I've already alluded to that just briefly, but this is where the wrong site, wrong procedure, wrong patient was done. So this is considered what they call a sentinel event or a never event. And these are covered by the Joint Commission. Sentinel events, and the Never events by the National Quality Forum. So the wrong side of surgery, they did surgery on the wrong side. Wrong procedure, it was done incorrectly. Wrong patient surgery, patient undergoes surgical procedure intended for another patient. I couldn't imagine. And there are some rare events. Look on page 2896, and it says 1 in every 112,000 surgical procedures, averaging one such error every 5 to 10 years in a given healthcare facility. Some factors: inadequate patient assessment, inadequate safety culture, poor communication, and so forth. Nobody spoke up. And so you want to look at page 2896, and it talks about speaking up, the Speak Up acronym. Speak up if you have questions or concerns. Pay attention when you receive care, medicines, treatments, and encourage your patients to pay attention. Educate yourself about the illness. Ask a trusted friend or family member to advocate for you. Know your medicines and why you're taking them. Because sometimes the physician will order something and the patient will say, I don't take that. And you have to explain, well, your blood pressure's up. They're giving you this to help monitor your blood pressure. Or you've got a urinary tract infection. You're getting this antibiotic. Factors that we look at for the wrong site, again, inadequate patient assessment, communication failures. A lot of times it's just a poor communication, whether it's in writing or verbal. Writing, did they mark the right site? Was it put in the record correctly? The other day I was on the unit and we had a patient and their name and date of birth did not match up with what the patient told us. Well, come to find out, that was put in there that way for a reason, and we were shown how to go in the system and find the name and the correct name and date of birth. So sometimes there's things that you may see that you have to clarify as well. Serious patient risk, they're subjected to severe unnecessary trauma. There's repercussions for the surgical team. You can be sued and be caught in a legal battle about the wrong site and wrong procedure. Pediatric patients, so what are our safety concerns for them? Keep medications, sharp objects, and equipment out of reach. They're children, they don't know what it is. Suggest that parents bring a few comfort items the child's familiar with. Maintain the child's daily routine and habits as much as possible. Suggest that parents help child stay busy with age-appropriate activities. Divert their attention from, trying to get into things in the room. Be aware when parents leave the child alone. Most facilities do not want the child left alone. Remember that children and infants move quickly. They can fall from the crib or bed. Communication with children using their appropriate language. You have to get on their level. Ensure that patients wear their ID bands at all times. If it won't fit on the arm, you may have to put it on the foot. Provide patient-centered care that engages the family and the patient. Stay within arm's reach whenever your baby's near water. Never leave a child alone in a bathtub, and check the temperature of the water. And then there's gun safety. Keep it up and away. Yes, we have firearms in our home, and when our grandchildren come, they are put up and away, hid, out of reach, and locked away. Have a lock box for your firearms. Pregnant patients need to follow healthcare prenatal guidelines. If they have chronic conditions, they may need to stop certain medicines during pregnancy that could harm the fetus. Patients need to know how medications and procedures are going to affect their pregnancy or child. Nurses can encourage patients to do safety behaviors. Be careful to avoid risk of infection, injuries, and accidents. Nurses can encourage patients to use the call button and make sure that they're not at risk for falls, especially someone that's pregnant. The newborn, teach the mother to never leave the baby alone in the room because the baby could be kidnapped. Give the baby only to personnel who have appropriate ID you know, because this is not a rare occasion that babies are kidnapped. Use infant crib when transporting. Don't never walk down the hall with the baby in your arms. Geriatric patients, encourage patient to have a family member or other trusted person to advocate for them. Know about over-the-counter medicines and herbal and dietary supplements and how they interact with your prescriptions. Information about allergies. You have to have this in the medical record. Even if the patient gives you something that doesn't sound like an allergy, if they feel like it was an allergy, you need to put it in there. Importance of teaching them how to use the call system and keeping it near them. Beds low and locked with the upper side rails raised so they can use them to help pull themselves up. Comfort items, and help family members and patients be comfortable with asking questions, and emphasize using that ID band. Communicate with them, discuss meal times, bathing procedures. All of these are important. Communication is the key. Giving orientation of person, place, and time. You know, I had one the other day, she didn't know where she was, and I said, well, you're at Cape Fear Valley Hospital. And she said, I am. I said, yes. And so you have to orient them to where they are. I told her what day it was and what time it was. So with our nursing process, safety is a common priority for many patients because of their sensory and motor changes. You want to protect them from acute or chronic conditions. Observation, history of falls, the medications, especially ones that drop the blood pressure, that's that orthostatic hypotension, chronic conditions. Can they walk good? Can they see, hear good? Changes in their vital signs. You know, how do their lungs sound? Do they have tremors? How's their balance? How's their blood pressure, pulse, and respiration? NANDA diagnoses, deficient knowledge related to their conditions, impaired skin integrity. That is a safety issue. We want to prevent pressure ulcers. Ineffective airway clearance. We want to make sure they're breathing, assess their lung sounds, assess their skin color, assess their oxygenation status. Ineffective thermoregulation. Are they running a fever? What does the temperature say? And risk for infection, especially those nosocomial. Planning. You want them to have clear breath sounds, be able to correctly demonstrate, you know, walking safely, remain free from infection, bleeding, falls, injury, poisoning, suicide. Yes, people do commit suicide in the hospital. I've seen it happen. Verbalize 3 things to do safely to get out of bed. So educate your patient, and when you educate, you have them return the demonstration or verbally say back to you what you said. That's how you know that they understood. If you just tell them and they can't repeat it back, how do you know they understand? Examples of interventions to promote safety. Assess patient's feet for cracking and dryness. Apply lotion. Well, if they're diabetic, they can get sores, get gangrene from that. Collaborate with physical therapists to teach patients how to use their walking devices, such as a cane or a walker. Encourage the patient to use their incentive spirometer every hour while awake. And one good thing I tell patients is every time a commercial comes on the TV, use your incentive spirometer 10 times, because usually they show commercials every 10 minutes. Staff will promptly respond when the call light goes off. Help them get up. Most injuries are caused because patients need to get up and go to the bathroom, and nobody gets there fast enough to help them, so they try to get up themselves because they don't want to wet and soil themselves. And then our outcome is that they've met all of these interventions. They're free from infection, free from injury, and that they have a quality outcome and able to go home.